Hi, this is Dr. Aidoo of the Department of Anatomy and Cell Biology, School of Medical Sciences, University of Cape Coast. I'm pleased to present to you cardiovascular system with respect to the heart. This is a sequel to an earlier video on blood vessels. Be my guest. So as part of introduction, we want to look at a vertical section through the heart, right from the apex all the way. You can observe the atrium, which is the right portion, the ventricle also right, and then this is the left chamber, so atrium and then ventricle. Then you can see here the SA node or the sinoatrial node, which is actually the pacemaker. The pacemaker because it's able to initiate its own electrical impulses. So we say that it is myogenic or inherent. So once it's able to generate these electrical impulses, it causes the atria to contract. And because it doesn't want to be selfish, it actually passes on or shares these electrical impulses it has generated inherently to the atrioventricular node, which is situated between the atrium and then the ventricle at the right side. So I mean the right atrium and then the right ventricle, which is the blue portion you see there. So this also relays the electrical impulses and in addition amplifies it, okay, towards the ventricles. And it does this by passing the baton to the atrioventricular bundle of His, okay, which also conducts it across the AV septum. That's the atrioventricular septum, which is this solid mass here. So you can see that the blue is branching into two and giving it to the yellow portion. That brings it all the way towards the apex of the heart and then transmit it to the rest of the ventricles on the left and then on the right. Now, this atrioventricular bundle is held, in place together with the septum by fibrous skeleton, as we will see in due course. Then, also interestingly, at the ventricular area, subendothelially, you have what we call the Purkinje fibres, okay, which also branches to supply both the ventricles apex first. All right, so these specialized cells, as we will see, are used not just like the ordinary myocytes. Okay, so they are conducting myocytes. So to add, the SA node is situated at the point where the superior vena cava enters the right atrium. Now, if you have watched the video on embryology, you realize that the vena cava are also portions that actually come from the sinus venosus, okay? And they get incorporated into the atrium. So you can refer to that video. So again, in a different diagram, we have SA node at the point where the superior vena cava enters the right atrium. You can see branches that are going towards the left atrium. So it helps the atria to contract. And you can also see its connection to the AV node, all right, which will therefore relay and amplify it through the AV bundle of His. Actually, this His is a person's name, okay? So note that the scientist who discovered it. And then the bundle of His branches into a right branch bundle and then a left bundle branch. Then these are the Purkinje fibers, which are subendothelial. We will see them in details when we look at micrographs. And obviously, that will be the apex of the heart, and that is the aorta and its arch, and then the descending portion as well. Then obviously, You have the pulmonary artery, then the pulmonary veins. So in the heart wall, what do we see? A section through the heart wall will show three main layers. So from within outwards, we're starting from within and then we are going outwards. You have the endocardium. So the endocardium is made up of endothelium and connective tissue, just like the tunica intima we saw in the blood vessel. Then as you go deeper, you have the myocardium. And if I say deep, I mean we are traveling from the endocardium and then going outwards. So we are going deep towards the outer portion. So that is thick cardiac muscle, also like the tunica media of the blood vessel. Then you also have the epicardium, which is the visceral pericardium. It's actually simple squamous epithelium with some fatty connective tissue, as you can see there. Okay. Right. So that is cardiac skeleton, which usually supports the valves in the heart. So that's the atrioventricular valve. The AV valve margins are supported by chordae tendon and papillary muscle. So atrioventricular valve, which one of it is here between the atrium and then the ventricle. So you have one here and it is supported by chordae tendon, as has been indicated here, which are these thread-like structures which are very strong. And then they are also held by the papillary muscles, as you find here. We know the source of the papillary muscle from the embryology video on the development of the heart. You can refer to that. Then obviously the left ventricle, right ventricle, and that is the bicuspid valve situated between the left atrium and then the left ventricle, then tricuspid valve because it has three cuffs, okay, within the right atrium and then right ventricle. Then that is the semilunar valve, pulmonary semilunar valve, right? So the atrioventricular valve, as indicated here with this special stain, will be supported by the fibrous skeleton, just as the human body is supported by the skeleton. So valves arise from the fibrous skeleton. The valve leaflet is dense, irregular connective tissue, contains a lot of collagen and elastin. The valve is covered with endothelium, okay, which is the innermost layer of the heart. In the heart, there are atrioventricular valves, which are tricuspid, mitral, or bicuspid, which we looked at earlier, and semilunar valves, aorta, or the pulmonary areas. So types of cardiac myocytes. So there are two main types of muscles in the heart. You have the conducting myocytes, known as the Purkinje fibers or Purkinje cells. There's also Purkinje cells in the brain, but we are talking of the one in the heart. So conducting myocytes. Then you also have the working or ordinary myocytes, which are contractile, which are usually the myocytes that do the usual and normal contraction of the heart. Okay, so those are the two different types. So how will you be able to differentiate between the two? So the Purkinje fibers, which are the conducting ones, are found deep to the endocardium. So we call that the subendocardial layer. So if this is the endocardium, the innermost layer, deep to it, you have the conducting myocytes or the Purkinje fibers there. The conducting or Purkinje fibers of the subendocardial conducting network are found within that region of the subendocardia. These fibers are myocytes joined by intercalated discs. As we know, the ordinary ones are joined by intercalated discs, right? However, these are specialized for impulse conduction rather than just contraction, okay? So just like any skeletal muscle, striated muscle, and for that matter, that of the cardiac muscles, they are also striated and they can undergo contraction and relaxation. However, for this particular Purkinje fibers, they are specialized for what? Conducting and not just contraction. Purkinje fibers are usually larger than the contractile cardiac muscle fibers, all right? So again, the difference between the contractile ordinary cardiac muscle cells or fibers are the fact that they are smaller than the Purkinje fibers. So Purkinje fibers are larger. In fact, when you look at these cells, which are the Purkinje cells, here as well, they are actually larger than the ordinary working myocytes. And they have one or two centrally placed nuclei, and their cytoplasm is also rich in mitochondria and glycogen, okay, relatively to the normal one. The normal ones also have similar characteristics of this last point, okay, but relatively, the Purkinje ones will have more of each of the points we have raised, okay, in terms of mitochondria and glycogen than the ordinary or the contractile myocyte. So Purkinje cells or the fibers, human heart. So these are usual cardiac muscle cells which do the normal contraction. Okay, so I call them ordinary myocytes, okay, or working myocytes. Then these ones are conducting myocytes. They are larger. So remember we said they are located deep to the endocardium, which we call the subendocardia because it is below the endocardium. So subendocardia layer. That is the lumen of the ventricle. And that is the endocardium. And deep to that, you have the Purkinje cells. So you can see that all these regions will contain Purkinje cells compared to this portion. And you can see there's a difference between the appearance of this region and that. So when we zoom in more, you see that this is actually revealing more of the Purkinje cells area. So large or elastic arteries were covered in the lecture on the blood vessels in part 1 of this lecture. The wall of the aorta has something similar to that of the large or elastic artery. So that is what you have here. So large arteries, aorta, pulmonary, brachiocephalic, common carotid, intima has abundant elastic fibers oriented longitudinally. Remember that the adventitia also, as we said, with the characteristics of these arteries also run longitudinally along the direction of the blood vessel, okay, and if you like, blood flow, whilst the media was concentric. Okay, so media has abundant concentric elastic sheets, fenestrated and smooth muscle cells that make the extracellular matrix and elastic sheets. We also talked about fenestration when we were looking at the type of capillaries. So intima has abundant elastic fibers oriented longitudinally. The boundary between the intima and media often are unclear by light microscope, but obviously with EM, electron microscope, you can see that. Then adventitia is rather very thin, as you can see here. So that is what you are looking at. And you can see the vast tunica media, if you like, made up of a lot of elastic sheets, and then smooth muscles. So wall of the aorta. Again, this is the wall of the aorta stained with this special stain, elastin. So you can see all the dark regions you see there are actually elastic fibers, right? Large veins, inferior vena cava, very low power. Large veins, vena cava, external jugular, pulmonary, external iliac. Then wall is quite thin compared to that of the arteries. So intima, the media thin or absent. And then you also have longitudinally oriented smooth muscle bundles, and valves are absent at this point. But usually, veins will have valves, but in these regions of the large vein, as we are looking at on the face of it, it doesn't have valves. The wall of vena cava, intima, media, adventitia. So its adventitia is rather large relative to that of the aorta. So wall of the vena cava showing longitudinal smooth muscles in adventitia. So those are the longitudinal smooth muscle. Remember, this direction is similar to that of the intima. Okay. Then also we have lymphatic vessels. They are similar to veins, but they have a few differences, as you see. So lymphatic vessels drain excess fluid from the tissues. Okay, so at the extracellular level, the extracellular tissue fluid, when they collect and they are not being used up, they are drained by the lymphatic vessels. So they begin as blind lymphatic capillaries, which take up excess tissue fluid. Lymph vessels contain no RBCs, but have some lymphocytes. Lymph flows through larger and larger collecting vessels with histology resembling that of venules and veins with valves. Occasional lymph nodes are interposed in the lymphatic vessel pathway. Okay, so in between, along the pathways, you have these lymph nodes, okay, serving as, points in between one long length of lymphatic vessel and the other. So a collection of lymph nodes. Obviously, they perform some immune functions because they can become inflamed, and that will be a sign of infection. So the lymph flows through them, and then they're able to trap some of the microorganisms. So macrophages monitor the lymph. Lymphocytes may engage in immune activities. Lymph reaches the thoracic duct and right lymphatic duct, both of which empty lymph into veins at the base of the neck, thus restoring the fluid, okay, and any content. So you return whatever seeped out of the blood at the capillary level, okay, into the tissues. You restore it, and then you have the blood contents reconstituted. So here you have the lumen of a lymphatic vessel. There's a cross section, and you can see that 8 cells, like the endothelial cells, they end up overlapping. They don't meet end to end, as you can see. So there's an overlapping. That's one of the striking difference between a blood vessel, as in a vein, and that of what a lymphatic vessel. Then you also see anchoring filaments there. So they have overlapping free borders of endothelial cells and discontinuous, endothelial cells, and then the basal lamina. So you can see that the basal lamina are discontinuous, where the arrows are pointing at. And these ones are the anchoring fibrils, AF. So again, we can compare histologically with this micrograph, a vein and a lymphatic vessel. So that's a vein. We know veins are collapsed a bit relative to arteries. They are not too concentric. They are more oval. And the same applies to the lymphatic vessel, a bit oval. And then veins also will have valves, just as lymphatic vessels also have valves. But as we said, their endothelial cells overlap. Okay, and you also have anchoring fibres and also discontinuous basal lamina. All right, you can see a lot of RBCs also in the veins. You don't have RBCs in lymphatic vessels. And obviously the veins are also larger in comparison to this lymphatic vessel. So thank you very much, and I hope this video helps.